Good afternoon, dear chairmen and colleagues. Thank you for the opportunity to talk about the bicuspid aortic valve and ascending aorta. Some facts about the bicuspid aortic valve. Da Vinci did some drawings about the aortic valve geometry, and that was the first mentioning of the bicuspid aortic valve, as you can see here. It belongs to the royal collection and to the Queen. So the incidence of bicuspid aortic valve is around 1 to 2%. So it's the most common congenital heart defect. And there is a male predominance as the ratio is 3 to 1 to 4 to 1. The disorder is from the valvulogenesis and is coexisting genetic disorders of the aorta and cardiac development. And typically, we have two unequal sized leaflets, and often we have the central rougher or ridge, and it is because of the fusion of the commissures, and this is the larger cusp, and the fusion of the right and the non-coronary cusp is mostly associated with cuspal pathology. Around 2% of children have clinically significant disease of the bicuspid aortic valve, but mostly there are no clinical symptoms. But during lifetime, 30 to 75% will require aortic valve surgery, and just 20% will remain competent for a lifetime. So there are a couple of classifications, and Professor Sievers from Lübeck, he did a Sievers classification, and the main category where we kind of classify the rougher is if there is a rougher or there is no rougher, and if you have one or two roughers. So in type 0, we have this perfect bicuspid aortic valve where both leaflets are nearly the same size, and you can kind of subcategorize because of the aortic buttons, the lateral and the AP. The most common form is the type 1, where you have a fusion of two commissures and you have one rougher. And nearly 70% of the patient with bicuspid aortic valve in his group showed a fusion between the left and the right coronary cusp. And very rare, there is a fusion between the non and the left commissures. Also very rare, and this is mostly patient, I think, where we see the neonatal age, this may be also critical aortic stenosis, where you have this two roughers and nearly just kind of unileaflet cusp. And there are a lot of associated anomalies, but coarctation is the most common, and nearly 50% of patients to 75% of patients with coarctation also present with the bicuspid aortic valve. And especially, again, the fusion of the right and left cusp. And we have seen some familiar descriptions of bicuspid aortic valves, but Kripe showed in her paper in Circulation that almost entirely there is genetic determination, and so it's heritable. So the recommendation is that first-degree relatives of patients with bicuspid aortic valve should be evaluated for bicuspid aortic valve and aortopathy. So a lot of patients with this disease will develop aortic stenosis during adulthood, and it is related to the increased macrophage infiltration and neovascularization of the bicuspid aortic valve, leading to stenosis. So there is this aggressive inflammation process, but more concerning is the dilatation of the ascending aorta. Usually the diameter increase of 50% is a borderline between ectasia and aneurysm, and Hanuxela looked at radiographic data of normal population and calculated the upper range of the aorta or ascending aorta diameter depending on the age. So the average diameter in a 20-year-old person is around 27, but the upper limit is 40. And the aorta in everybody grows with age, but there's, of course, this upper threshold. It gives us a kind of a benchmark, but it's not, yeah. So aortopathy is the most commonest finding in bicuspid aortic valve. So already Abbott described 1978 that there is an association between bicuspid aortic valve and aortic disease. And in 1972, McCusick described these cystic medial necrosis. Often the aorta is elongated, asymmetric, enlarged, and there's the loss of this elastic properties and becomes stiff. And 3% of the pediatric population already shows dilatation, and 30 to 80% in adults. So the dissection rate is around 2 to 5%, and patients with the acute dissection, 50% of these patients have a bicuspid aortic valve. So histopathologically, there are cellular, of course, abnormalities. The group in Toronto showed there's an increased MMP level or MMP activity, and so we have decreased fibrinogen, and there is accumulation of basophilic ground substance. And we didn't know much about the natural history of bicuspid aortic valve, but recently there were a couple of cohort studies, and Michelina showed that, or followed people in Minnesota, and she showed that although they don't have any symptoms and they had normal functioning or minimal dysfunctional bicuspid aortic valve, approximately 4 out of 10 developed dilatation of the ascending aorta, more than 4 centimeter in diameter. And there was this increased frequency of cardiac events like aortic valve surgery or any other cardiovascular surgery. And predictive factors were age, above 50 years, valve degeneration at diagnosis, and a baseline ascending aorta of bigger than 4 centimeter. So there was a follow-up study, and she did an incidence study, and the only multivariate predictor was aortic stenosis. And again, of course, diameter above 4%. So another big cohort study, which was done by Semos, he followed nearly 650 patients for nearly 10 years. And 25% had 1 or more cardiac events. So predictors for these cardiac events were age above 30, and moderate or severe aortic stenosis or regurgitation. And if you had more than 1 risk factor, the risk increased very high for primary cardiac event. So aortic dilatation is a problem. And aortic dilatation, it is not related to hemodynamics. So the NISTRI looked at young men who had normally functioning bicuspid aortic valve, and he could show that to the compared group, the group with the bicuspid aortic valve had bigger annulus, had bigger ascending aorta, and the sinuses of Valsalva were also bigger. So the bicuspid aortic valve is associated with aortic dilatation, and it is out of proportion to coexisting valvular lesions, Keene showed. So regardless if you have aortic insufficiency or aortic stenosis and probably more shear stress, you will get an aortic dilatation or can get an aortic dilatation. So with aortic dilatation, we always fear dissection. And Davis and his group in Yale, Eleftheriadis, showed in their landmark paper that there is this inflection point. If you have aortic diameter bigger than 5.5, the risk to get the dissection is high. So the recommendation is to replace the aorta which is bigger than 5.5. So we lower the risk, or we lower the thresholds for people with Marfan syndrome. But what do we do with people with bicuspid aortic valve? So Russo looked with his Italian group people who already received an aortic valve replacement with bicuspid aortic valve and compared it with people with tricuspid aortic valve after aortic valve replacement. Sorry. And he showed that the people with the tricuspid aortic and normal valve didn't have any events in this 10 years, but the people who had a bicuspid aortic valve, so the group A, 5 people had a sudden death and 5 people had a dissection. And also Yasuda showed if you replace the aortic valve, still there is this progressive dilatation of the ascending aorta. And but what about children? There's this bigger study, and I think one of the only studies about progressive dilatation of the ascending aorta. And she recommended that children should get serial echocardiograms and should be followed frequently. So when should the aorta or ascending aorta then replaced, or should we replace this more frequently? Was the question Michael Borger asked when he was in Toronto. He was my senior consultant when I was in Leipzig, and he showed in a follow-up study, it was retrospective when he was with Tyron David, that a larger diameter than 4.5 was a risk factor. And the group in Yale with Davis again, they calculated an aortic size index, and he looked at the aortic sizes or diameters and also the body surface area. And you can see from this chart there are people who have lower risk, these are in the pink group, or they have a severe risk in the green or dark green group. So you can look up if your patient has a higher risk for dissection and or primary cardiac event. Recently, Svensson in the Cleveland Clinic looked at their really big group or cohort. They looked at nearly 2,000 patients, and they also showed that the larger aortic size, more than 4.5, was a trigger for recurrent aortic repair. These are 4D MRR flow studies, and this is the normal aorta, this is a dilated aorta, and this is a bicuspid. Although there are maybe not that much CS as we expected, but there are, of course, flow differences and flow pattern differences. So there are different classification models to describe aortic dilatation. And Sund, for example, describes type A, B, and C. So if you have an enlargement of the ascending aorta above the sinotubular junction, then so the ascending aorta is type A, type 1, sorry. Type 2 is the aortic root is enlarged and the ascending aorta is enlarged, and type 3, just the aortic root is enlarged. Faisal, when he was, I think, also in Toronto, but later I will show another study when he was in San Francisco, showed that the highest cluster was where we have already also had a root and an arched dilatation. And then he found also ascending and arch dilatation in 30% and just root and ascending in 15%. So what are the surgical options? You can do a reinforcement, so you wrap the aorta, or maybe also make the aortic size smaller and wrap it in Dacron. But as the dilatation still goes on and it is tissue related, you can still have aortic dissection, and you can also have aortic dissection without aneurysm. So other possibilities, if you perhaps have type A, you can cut the ascending aorta away and replace it with graft, a Dacron graft, above the sinotubular junction. And of course, it depends on how competent the valve is and if you need a reconstruction of the valve or not. But most of the times, if you have just an aneurysm in this part, so type 1, you just need graft replaced or ascending aorta replaced above the sinotubular junction. So if you have aortic root and ascending aorta dilatation, it depends mainly on the valve. If you have severe aortic stenosis or insufficiency, usually you can't do anything with the valve and the valve needs to be replaced. And then you can do a composite valve graft, either mechanical or biological. So if you do a mechanical, this will be the Benthal operation. If you do a biological, then you either have to saw it yourself, most of the time. These patients also can get a valve-sparing root replacement, which I will show later. But first, let us look a little bit to the Benthal operation. So you excise the aortic valve, you put a mechanical valve in. Either you saw it yourself or it is already made in the factory, so then it is a composite graft. And so the aortic valve is removed, the ascending aorta is removed, the coronary buttons are cut out, and the ascending aorta is replaced entirely, and you have to re-implant the coronary arteries. If you have just a root dilatation, you can use biological root replacement with a freestyle graft. It is shown here. It is from a pig, and it's a full root from a pig, and you cut holes into the root and implant the coronary buttons. Another option is, of course, the David operation. This is the re-implantation technique. You remove the ascending aorta, you move the sinus of Valsalva, you reconstruct the whole aortic root with the Dacron or Valsalva tube, and then as you kind of make the aortic annulus smaller with this graft, the valve becomes competent again, and you also have to re-implant the coronary buttons. Another technique described by Lange is a remodeling and subvalvular external aortic annuloplasty. So you tailor a Valsalva graft, you sew it to the aortic root and the commissures, or neosinuses, sorry, and you have this extensible aortic ring. You put it underneath, but from external, underneath your Valsalva tube, and kind of reconstruct the aortic annulus with this ring. So what's the benefit of this, and what's the difference between the David operation and this remodeling and subvalvular annuloplasty? So if you look at the remodeling, what Jakub did, you just kind of replace the aorta with the tube above the sinotubular junction and of the sinus of Valsalva. And in David operation, we re-implant everything, and you make kind of the root completely stuck. Lange believes that with this technique, you have still the extensibility of the root and of the interleafed triangles. So this is the benefit of this operation. Sometimes, but very seldom, you can just replace the valve and the ascending aorta. But to what extent, or to what distal extent should we replace the aorta? So if you look at embryogenesis, you can see that this part of the aorta, the aortic valve, the ascending aorta to the ligamentum of arteriosus, and the main pulmonary trunk is derived from the neural crest. And so in bicuspid aortic valve disease, you have medial necrosis of all this part, usually. So here till here. So Faisal, when he was with Craig Miller in San Francisco, looked at the transverse aortic arch, and he could show that often the aortic arch is also involved, and the aortic arch should be also replaced. So what Craig Miller does is this extensive aortic arch replacement. He doesn't call it hemi-arch, but he kind of saw it till here. So should we really replace it routinely, the proximal aortic arch, in every patient? Asked Park. And he concluded it is not that often really needed, and you should replace it appropriately to the patient needs, because it's still a big operation, although usually it takes 15 minutes for the anastomosis, and but still you have kind of to cool the patient down and do the extensive arch replacement. So there are a couple of other studies regarding the aortic valve, if you have regurgitant or stenotic aortic valve, and the size of the aorta and the aneurysm of the aorta. And for example, Robert showed that patients with aortic insufficiency have a higher significant likelihood of elastic fiber loss. So there is more risk for aortic aneurysm. But what about the repair of bicuspid aortic valve in patients with aortic regurgitation? So compared to tricuspid aortic valve, we said it's an ongoing disease. So if we repair it, what will be with the bicuspid aortic valve in the long term? There aren't that many long-term studies, but kind of early and middle. And El-Khoury and his Belgian group showed that there are good results also after repair of the bicuspid aortic valve. Of course, it's a problematic population. Of course, you have, as I said, one leaflet is always bigger than the other, usually, and you don't have that often this perfect zero commissure. And so it's really not easy to kind of reconstruct it and have a good result afterwards. But a couple of groups showed, also Eicher, the Schäfer's group, showed that you can have reasonable results, and compared to tricuspid valves, for example, here in the follow-up, there was less aortic regurgitation. Yeah, it was interesting, but freedom from reoperation was, worse. So she also noticed recently that it was dependent how the bicuspid and commissural orientation was. So if you look at the bicuspid aortic valve and see that the risk or the commissural orientation is maybe not favorable, maybe you should replace it and not reconstruct it, because she showed there was really a difference significantly between these groups. So there was this meta-analysis of valve preservation surgery in bicuspid aortic valve. And of course, there are different techniques and also different ways to describe the results. So it's not comparable. But the group showed in her review that bicuspid aortic valve repair is safe and efficacious. And, but we need further standardization of outcome, of course. And you always have to keep in mind that usually these are young people or patients, and if you replace the valve with a mechanical valve, of course, the incidence is low for complication like bleeding, valve thrombosis, or embolic events. but there is accumulative risk because they will have the valve for maybe 50 years. So one really has to think about the anatomy and the possibility to reconstruct it. And there is still a risk if you just replace it with a mechanical valve. But what about the Ross procedure in bicuspid aortic valve? It's not really recommended, but some people tried it. And soon did some, or showed some patient where he had to replace the neo-aorta again because it became so big. And interestingly, on Monday, we have a case, a similar case. It is a patient who had a Ross procedure and now has aortic diameter size of 7 centimeters. So he needs aortic ascending aorta replacement. So why is it? As I said, the neural crest, it's also derived this ascending aorta and also the main pulmonary artery or trunk. So when you have bicuspid aortic valve patients, the medial degeneration is not only at the ascending aorta, it's also in the pulmonary trunk David showed. So Ross procedure is not really an option. So when he was with Grieb in New York and then he stayed with us in Leipzig, he looked at people with bicuspid aortic valve and modestly dilated ascending aorta. And then he asked himself, what should we do with those patients? They just have a modestly dilated ascending aorta, they have this bicuspid aortic valve, but still mostly they will dilate. And his study showed that if you have people under surveillance and compared to people with immediate surgery, the diameter, of course, are different. Yeah? And of course, their diameter are above the upper limits. I showed what Hanuskesela already showed in the slide before. And they followed a lot of people with the ascending aorta and looked at the growth of the ascending aorta. So the people received a CT or MRI every year. And you can see that the aorta, ascending aorta growth was 0.7. In normal age-related population, the growth would be just 0.16. So there was really a growth rate. But the growth rate, interestingly, was not associated with hypertension, not with sex or age or smoking. Yeah. And when he matched it with the age and sex match New York State population, he showed there was no real difference if you have people under surveillance or normal peers. So the AHA guidelines recommend that there should be a yearly evaluation of patients with bicuspid aortic valve with a diameter bigger than 4 centimeters, is class 1 level C. That, as I said before, the relatives of bicuspid aortic valve should always get an echo, CT, and MRI. Replacement of the ascending aorta is recommended above 5 centimeters. And also an aneurysmal growth above 0.5 per year. And if you have to do another surgery in the patient, maybe because he needs cabbages, because then the recommendation is you should even do it if the aortic diameter is 4.5. Thank you for your attention.